Welcome everyone to our November Associates Meeting here at SIEPR. I'm Mark Duggan, I'm the director of SIEPR, and it's really wonderful to have all of you with us today. I really appreciate the way that so many of you here support SIEPR, and having you attend these events like today's is a great way for you to learn more about what we're up to and the fields of research that we at SIEPR are most interested in. Before I talk about today's event, in just a few weeks on December 5th, I hope to see many of you back here for the State of the West Symposium that we'll co-host with our friends from the Bill Lane Center for the American West. Speaking at this event will be the Governor of Nevada, Brian Sandoval, along with Randall Quarles, the Vice Chairman for Supervision at the Federal Reserve. And as all of you know, we always do our absolute best to line up the best speakers that we can on any given topic. And I feel like we absolutely hit the mark today. Today's speaker, Steve Nelson, is the CEO of UnitedHealthcare, which is the country's largest health insurer, serving 1 in 8 Americans. I was interested to learn, this was a surprise to me, even though I think of myself as a health economist who knows a lot about healthcare, surprise to me to see that United weighs in at number 5 on the Fortune 500 list, just behind Apple and ahead of Amazon. So to me, that just gives a sense of how big this company is, and they've been doing spectacularly well under Steve's leadership over the last couple of years. It's been increasing its membership, particularly in its Medicare Advantage and Medicaid business, and the company expects, I think, those numbers to continue increasing given all the great things that it's doing, but also demographic and policy changes here today. And I'm really, especially for me, thrilled that Steve is here today, seeing as how much of my own research has focused on the private healthcare sector as well as on Medicare and Medicaid. So I will do my best. I've been told many times that I ask too many questions and I don't leave enough time for audience to ask, so I will try my best to not take over all of the time after Steve's remarks. And I also want to give Steve a huge thank you for meeting with a group of students here earlier today, giving Stanford students the opportunity to ask questions and hear directly from leaders like Steve is a big part of what we're trying to do here at SIEPR, and I'm really thrilled that we had the opportunity to do that here today. Since taking charge of UnitedHealthcare, Steve has focused a lot of attention on how to streamline the health insurance industry and create an environment where health professionals and consumers act, as he puts it, as full partners in health and well-being. And that includes looking at new ways to use data and technology to create a more personalized and easier to navigate healthcare system. He'll be sharing some of that with us today, as the title of his talk is Redefining the Healthcare Experience One Person at a Time. Before he became the CEO of UnitedHealthcare, Steve was the CEO of the company's Medicare and retirement business, the nation's largest organization dedicated to seniors and Medicare recipients. Other past roles include leading UnitedHealthcare's community and state business, an organization that delivers Medicaid solutions in 30 states and the District of Columbia, serving nearly 7 million beneficiaries. Prior to joining UnitedHealthcare, Steve was president of the Eastern Region and Senior Products Division at HealthNet and served for 10 years in executive roles at the Henry Ford Health System. And in addition to all of these professional accomplishments, Steve has somehow managed to find the time to train as a triathlete and is a five-time Ironman finisher. So pretty darn impressive. And I had the pleasure of meeting Steve earlier this year when I was invited to speak at the Kellogg School of Management by a former advisee of mine who's now on the faculty there, and who invited me and said, Mark, I'd like to invite you to be the keynote speaker at our conference, at our annual conference. It's a big deal. And I thought, oh, that keynote, that sounds pretty good. And then I arrived for the conference and I learned that I wasn't the real keynote. The real keynote was Steve. I was the warm-up act for Steve. And it was, so that was fun. But it was great. And there I connected with him and was so thrilled to get him out here based on what he said there. Steve earned his Bachelor of Arts degree from Portland State Universities and holds master's degrees in business administration and in health services administration from the University of Michigan, where he also serves as an adjunct professor in the School of Public Health. He's apparently also an avid fan of Michigan football. And I would have hoped when we first had this event weeks ago, thinking about this event, I might have thought, well, maybe Stanford and Michigan would be on track for a Rose Bowl. But for various reasons, it looks like one of them is maybe soaring above Rose Bowl and the other one not quite reaching it. So in any case, I guess we won't see that this year, but hopefully in the future. But in any case, please join me in welcoming Steve Nelson to SIEPR.
Thanks, Mark. Appreciate the kind introduction. And I have the opportunity to speak in a variety of settings, and it is always really interesting who you kind of end up speaking before and after, and I actually, it's funny, Mark said that I shared this with the earlier group, but I was intimidated that I was following him because, he's a professor and I just do the practical stuff, and so it was great to hear him talk about his work, and it was actually pretty inspiring. It was helpful. So we're going to leverage some of the work that he's doing and try to continue to build on our relationship. So anyway, and UnitedHealthcare, for all the work that we do across the country, we Northern California is an interesting healthcare community, and so there's a lot to work on here as well. And so anyway, a lot of reasons that I'm grateful for the invitation. I am sorry to hear about the fires north of here. It delayed our flight this morning coming here significantly, and it's pretty, when you fly over, and if anybody's done that recently, it's pretty disturbing. We actually have a call center in Chico, so several hours. We're gonna go visit that site tomorrow while we're here and go say hello to, we have about 350 or so folks that work in that call center. 125 at last count lost their homes. And so, it's just devastating, and so we're gonna go up there and spend some time with them tomorrow and buy them lunch and try to raise their spirits, but it's a tough thing to see. So I hope that, we can get that under control. I used to live in Southern California, and so I'm used to the pros and cons of living in California. And I lived in Laguna Beach, and we had this massive mudslide that came through and just sort of wiped out sort of the center of Laguna Beach, and people would be like, "Why do you live there?" I'm like, "You got to come spend some time here." It's pretty nice. But so it's a great opportunity to spend some time with you. I want to talk a little bit about, one of the most popular questions that I get asked is, why is healthcare broken? Why is it so expensive? And, that's like, okay, this is going to take a little while to explain, but I'd like to start with some things that I know most of you already know, but just to kind of set context for the rest of the conversation tonight. As you know, healthcare expenditures in the US anyway are climbing. It's alarming, and it's a huge percentage of our economy, and it's getting bigger. And so that has got a lot of people's attention for a lot of reasons, some good, some not so good. But this is in combination with the fact that it's not just a macro trend, it actually hits us very personally. So it's not, the rising cost of healthcare is outpacing our wages and incomes, and so it definitely feels personal. And then what's interesting is we're not really spending the money in the same ways or the same places that other countries are, or at least our peer countries. This is from a book called The American Healthcare Paradox that compares our country to 30 other countries. How do we spend our money? What are the outcomes? And what this would show is that we actually spend about half as much on social services, the things outside of the traditional walls of healthcare, and we spend twice as much on what we would consider to be the traditional sources of healthcare. And yet our outcomes are not as good. And so it's kind of an interesting, as the book title would suggest, paradox, where we're spending a lot of money, we're not necessarily spending it in the right ways, and we're not getting the best results. Now, I don't want to be super negative because there is much to love about our healthcare system. We have the opportunity to serve 7 or 8 million folks in South America and operate 54 hospitals in 4 different countries in South America. And so we spend a lot of time in other countries, and where you have 85% of the births in Brazil are through C-section. Other countries have issues too, but this is definitely a challenge, for us to think about. And this is a very quick way of saying we have a problem. Would you agree? So that's, and then chronic diseases on the rise too, with our aging population, and not only is it is it increasing in the elderly, but it's in actually throughout the population generally. Diabetes is rampant throughout all populations. It tends to be associated with elderly because that's a sort of a popular correlation to make, but and we were just talking earlier, it is actually really on the rise in all of our across all the populations, even in our youth. So some real issues. And then interesting idea about this, how do we spend our money? 80% of our health is actually affected by things outside of traditional healthcare venues, hospitals, doctors' offices, 80%. And that's lifestyle, it's your environment, it's your economic situation, your education, all these different things, housing, transportation, food stability, all those things dramatically affect our healthcare, yet we really focus on 20% of how we get our health care. That seems to be all the attention. If you go to Washington, D.C., or you go any place, the conversations are around the 20%. And that's sort of the traditional sources of healthcare and where we spend our money. So that's out of balance and out of whack. This is, I have 7 grandkids. He is the youngest, Bennett. He looks really happy here. Because he has a s'more. You guys know what a s'more is? Diabetes, pre-diabetic waiting to happen. But you know what? It's a s'more. You gotta have it. But he happens to have a double ear infection here. And our family, earlier this year, we traveled to the mountains in Wyoming together, and all the grandkids came, and Bennett, traveled with a double ear infection, which, as you kind of know, anybody has had that or been with a kid who's had that, it's tough to fly when you have that kind of pain. Anyway, so they get to the place, and we're in a remote location, and my daughter, Bennett's mom, realized that they had forgotten their antibiotics. And here they are, and of course this was the fault of Bennett's dad, who has an MBA from Kellogg. So, what can you do, right? But he, and so after we kind of rallied around Bennett's dad to protect him, my daughter launched into, well, I need to get this, so we were kind of a remote location, not a lot of access to healthcare. And so she called the doctor's office back in Chicago and said, could you call in a new prescription? It's about a 45-minute drive for me to go to the drugstore, but I can do that. I just need it refilled. They're like, no, can't do it. Somebody needs to see you, or I need to see you, or we can't just call it in. And of course, she's like, I literally just got it from you 2 days ago. It's like, this makes no sense. And so after exhausting herself, she finally breaks down, gets me, and she's like, hey, do you know someone? Because I got a problem, and I need to cut through the, what's going on here. And so anyway, it turns out I do know someone, and we were able to get this resolved. But it was ridiculous what we had to go through. And this is a very common scenario. I need access. I don't want to jump through a lot of hoops. It's very clear cut. Just help me solve this problem, right? Happens all the time. My mom and dad, my dad actually just passed away a few weeks ago. He was 88 years old. My mom's 84. He had chronic diabetes, and eventually we had to move, and she's on borderline dementia, and so we eventually moved them just recently, past 6 months, to assisted living. And what was interesting about sort of the process that I participated with them as they aged was how complicated it was to navigate the system. And I know what I'm doing. And I could hardly do it. And I needed a lot of help to do it. And that is ridiculous. That it took me personally to engage, and they were UnitedHealthcare too, and so I had every possible weapon at my disposal, and it was still super complicated. We had a continuous glucose monitor on him. I was able to monitor him on my phone. When he was pounding Red Bulls, we would know that. We don't know why he did it, but he wouldn't stop. So this whole conversation about there has got to be an easier way, and there are solutions out there, and there's a lot of other examples from other industries that I think are interesting to think about. Anybody remember Blockbuster? I hear there's one Blockbuster that remains. I think it's like in Seattle or something, kind of as a kind of a historic landmark. But we used to go get our movie entertainment. If we wanted to watch a movie at home, we would go here, true? Then now we go to Netflix. One of the most controversial conversations we have in our family is, what movie are we going to watch tonight? And we debate it, we watch 2-minute trailers for 2 hours, and then I'm exhausted, and I go to bed. But now we say, what does Netflix recommend based on our viewing history? And we pick one of those, and we go with it. And it usually turns out to be, pretty good. Why can't we do that in healthcare? Why can't we personalize and understand preferences and start dialing that in? Anybody remember going to the record store? All these things happened in most of our lives, actually, that are here. It wasn't very long ago. Now, we can stream music, our preference, and we don't even need to download it. We can just stream it. We don't even have to own it. You can just borrow it. If you don't mind putting up a little bit of commercials once in a while. And you can do it anywhere. You can do it in the airplane. You can do it in your car. You can do it in the mountains. I mean, it's pretty remarkable. Why can't we have access to healthcare like that? Who here likes to go to malls? Okay. Well, there you go. Okay, yeah, so it's a business. I actually, my wife and I actually we have this holiday pledge that we take, that starting Thanksgiving Day through January 2nd, we don't go to a mall on purpose, and it doesn't mean we don't buy anything, but we don't go to a mall, And what's interesting is there's people like to go, some people enjoy shopping as a hobby, but most people don't really love that experience of going, trying to pick out clothes, try it on in a dressing room, pick the wrong thing, the lighting's bad, all that kind of stuff, right? I mean, generally. Stitch Fix. So they show up and, they're like, hey, stay where you are. Try some stuff out. If you don't like it, send it back. And we'll just keep getting smarter about what you like and what you look good in. And we'll just keep sending you things. And it's going to be perfect. It's going to fit perfect. It's going to be exactly what you want. It's going to be in your price range. There's no downside. You can try it on, and we'll give you advice too, free. It's a pretty great model. Again, why is this not happening in healthcare? You see where I'm going with this? So expectations are changing. And we should be more demanding about where healthcare is going. And by the way, I'm not placing blame on any part of the healthcare system. There's a community in the healthcare that has a responsibility to try to fix this, and we as consumers should have it. So the idea is expectations are changing. The way we access healthcare, that idea is changing. We should be able to get it where we want it, how we want it. My daughter ended up actually using Doctor on Demand to access, and now it is actually, they broke a little bit of a rule because you cannot detect a viral ear infection or a bacterial ear infection through a scope, but there was enough corroborating evidence that they were able to call in the prescription. But that was $40 and it took 15 minutes, as opposed to the scenario where she was gonna have to drive 40 minutes into town, find an appointment with the doctor, so on and so forth. Expectations are changing, and actually none of my 4 millennial kids don't have a primary care doctor. They do this. And it doesn't have to be in your home, it can be anywhere. So this is what we're looking for. This is what's happening in other industries. Our mission at UnitedHealthcare, just to kind of make some connection between what the need is and where we're going and how we're thinking about it, is to help people live healthier lives, help the health system work better. And again, there's a lot of work to do, and I'm not saying we're perfect in everything that we do, but we have some ideas, and I want to share some of those with you, and then we can have a discussion about it. There's one of the things that is interesting about healthcare is how do you take all the existing technology, good thinking, and try to bring it into an industry that has kind of been set in its ways for a long time. And I know there's a lot of folks out here who are making change in healthcare. One of the ways that we do that is we try to create somewhat of a ambitious vision, and then we get people kind of excited about it, and then we reverse engineer back to the beginning, where we are today, how do we get there? So we created a video, and we started to use this video, it's about 5 minutes long, to help our internal employees think about what could the future look like, and how could we as UnitedHealthcare help build towards that future. And so I'm gonna show you this. It's 5 minutes long, and it's one day in the life of one family. And also I want you to know that this is not meant to exclude. It's full of technology and it's full of sort of what if scenarios. But I want you to just keep your mind open as you watch it, and then we'll talk about it. Did you find that interesting? Thought provoking at all? What's interesting about it is most of that technology exists today. So just think about. We'll just walk through the day a little bit. So she wakes up and she's getting health data on her son, running a temp, and she also is able to get some health data on her as she's brushing her teeth. That technology exists today. Health or Sleep Number, bed company, for example, they get 7 billion pieces of health data on their customers a night. Not just things like temp, but breathing patterns and sleep effectiveness and heart rate and all these things. So that exists. The idea of sharing, can you keep it private or can you share? They're making decisions on that. That exists, today too. This idea about scanning food in and out of your refrigerator, technology exists. I don't love that idea, but it exists. The ability to communicate with and be signaled, be alerted that Nana Nevins had elevated glucose levels, right? That was being triggered by a continuous glucose monitor. At the same time, just so happens that a UnitedHealthcare house calls nurse was in the room and we could make that happen because it's a movie. But we were able to do that, but we wanted to also demonstrate that no matter how technologically advanced we get, there's always going to be human touch in healthcare. And we do about 1.3, 1.4 almost million house call visits a year to our senior population to assess and help and do those kinds of things. Again, that stuff exists right now. The opportunity to do a remote visit, that technology exists. The only thing in this movie that is absolutely far-fetched and will never happen is when she said, "Call Dr. Clark," and Dr. Clark answered. Total fantasy. But then you go on to, and there's actually a quick thing that's hard to catch but she was able to, they had a real-time payment to her bill. It came out of her HSA. All that stuff was just instantaneous. And again, all that can happen today. We're working on all that. And then at the end, a drone, delivers the drugs. And again, technology exists. Would you agree? So most of this stuff, it's not that far-fetched. It's about bringing it together. And the underlying platform is an individual health record, a portable individual health record that has interoperability across the healthcare system. We're actually in the process of rolling out individual health record to 50 million Americans right now. That it's started already in several delivery systems last Monday, and it continues. And so we're after that right now, and there's no other company that's been able to do that. So these things are possible, and they can happen. This is for one family, certain socioeconomic category. It can also be applied, the same technology, different way, different demographics, different populations. We can make the same movie for a Medicaid population. We can make it for a senior. We can make it for what does it feel like when you go into a doctor's office? So all those things are in the works, and it's really exciting when you think about it. So there's definitely a digital data technology answer that is coming soon and already well in the works. But in addition to that, we need to get after this other idea of redefining what it means to have access to healthcare. So, and we're doing it in several ways. Just to kind of give you some examples. In our business specifically, we have people who and divisions that are dedicated to, we bought a transportation company. We're going to invest $350 million this year in affordable housing. And we're working with community agencies, I'll show you a couple pictures in a minute, about food stability. So this is actually part of our business, and this is how we work with states and the federal government and some employer groups too on these kinds of things. Social investments, talk about this more in a minute, about how we support the infrastructure and the agencies that are already out there, but they're underfunded and they're not very well, they don't have a lot of, they have a hard time attracting strong leadership, for example, and so what can we do to help strengthen them and connect the dots? And so we bring community health workers into the community to help do these kinds of things, and then these partnerships. So for example, working with Louisiana, Missouri, 2 states who are federally qualified health centers. These are the centers, health centers that serve typically the low income in the communities, and we've actually partnered with them not only financially, but we've sent actual workers trained to help bring more capabilities, more talent, more resources to them in the community. And it's been incredibly successful, and we're doing it in other places too. In Arizona, Wisconsin, we're working with organizations like Feed Wisconsin, where 40%, so that is a very disturbing statistic. 40% of the food in this country actually goes to waste, yet something like 40% of, 40 million people go to bed every night with food instability. These are kind of staggering, offsetting, there's a real dissonance there. So part of the issue isn't do we have food, it's how do you get it, transport it, and so refrigeration trucks, for example, we're investing in those and helping states use that to create more food stability. And these are, again, part of redefining what we mean by healthcare and actually getting pretty serious about it. Another interesting way to think about how do you impact someone's health, individual, this isn't his real name obviously, TJ, we identified him as part of our Medicaid population in Arizona where he had a scenario where over a 12-month period, he had 208 visits to the ER, 15 hospital admissions, and about 15,000 monthly healthcare bill. And it turns out that he's showing up at the ER with anxiety, some mental health issues, some addiction issues, and he's getting admitted because it looks like he's having a heart attack. But the reality is he's got a lot of anxiety and a bunch of other things going on because he didn't have a house, didn't have a job, the list goes on. So we were able to intervene, and we have these programs, and we call them HotSpotting, where we can actually detect this kind of pattern, and we can intervene in a very personal way and help TJ get housing, back to work training, help him think about food stability, those kinds of things, work on connecting with mental health providers, so on and so forth. As a result of that, many months later, not visiting the ER, going back to work, healthcare problem solved, had nothing to do with being in a doctor's office or in a hospital. Completely to do with these social determinants of health. The biggest driver of our health status right now is zip code and credit score. And we have to get after that. So these are some examples. And then there's a lot of opportunities to work differently with providers. We had the opportunity to meet with the dean of the medical school earlier. Is he here? No? But we had a great conversation about what can we do different together. So we've been partnering with a variety of health systems about how do we kind of work together in a different way that's unique, that will actually be transformative and move from volume to value and really drive outcomes, experience, and lower costs. And they have to kind of happen together. You can't kind of do one of those on its own or it doesn't make sense. And so getting really excited about that. We meet with about 50 or 60 of the largest healthcare systems twice a year and share ideas about what can we do better, what can they do better, how do we work together. And it's producing powerful results. And so just to kind of close, there's something that I firmly believe in, and again, ending where I started, where people say, why is the healthcare system broken? Or why is it so expensive, or whatever the form that the question comes. One of the issues is it's not really a system, and there's too many kind of silos, it's too fragmented, the incentives aren't aligned, all those kinds of things. So one of the things that I'm a big proponent of, and I've been doing this for 30 years, is the lines need to get blurry. We need to not think about, well, we do this and we own our data and we're not going to give it to you. We're worried about this and this is our view of the patient experience, and it starts when it comes to us and ends when it leaves us, but yet there's this whole life that's lived that we need to pay attention to. But we're not going to worry about that because we're not responsible. We need to have community agencies, payers, hospital systems, provide all kinds of providers, mental health community. The lines need to get blurred. And I believe if we can blur the lines, we can step back, and eventually we can see a masterpiece. So that was a close-up view of Monet's Dusk in Venice. Kind of ironically, Monet painted this when he was losing his eyesight. And it's just sort of powerful when you think about what could this thing look like. Think about the movie, think about this painting, think about your own experience, think about other industries. But there is clear opportunity and there is need. And I think, for one, I'm personally optimistic about it. It's way better today than it was 30 years ago, and 30 years from now it's going to be way better than it is today. And I think we're sort of in a period where we can expect some breakthroughs. So happy to answer questions.